So hello everyone, online and here at the microscope. I've got today a couple of basically very simple basic pathology cases. The first case is a biopsy from the stomach of 80-year-old male with a clinical history of anemia, and they are investigating why the gentleman has got anemia. So they have taken GIT biopsies. At this low magnification, we can see a little bit of reactive changes, mild foveolar hyperplasia, not really inflammation. Okay, so hyperplastic foveolae with some smooth muscle proliferation. So this is a pattern of reactive or chemical gastropathy. But in addition, in some parts, you can see this golden brown pigment. And you really don't need to do the histochemical stains, but I have performed staining, and it's this positive, okay? So this is so-called iron pill gastritis. This is caused by drugs, supplementation of iron, because the gentleman has got anemia, okay? And in addition to his anemia, now he's got erosions and problems with his stomach. Sometimes it's really subtle, and you have to be really careful with examination of the biopsy sample, because the deposits of this iron pigment is not so widespread like in this very nice example. So again, pattern of reactive or chemical gastropathy caused by iron pills, so-called iron pill gastropathy. This is another case. It's a second opinion. 43-year-old male with a tumor of testicle, and already in this very low magnification, you can see the solid tumorous proliferation. So this is really very simple, basic pathology. And with this morphology, roundish cells with very prominent nucleoli with some inflammatory cells in the background. Sometimes we may have epithelioid granulomas as well. The diagnosis is simple, it's classical seminoma. But the patient was diagnosed in the March this year, and I had a phone call 1 day ago from the oncologist that the patient has got lung metastatic disease, and her question is what it is, because it's not expected for pure seminoma to have recurrence in less than 1 year. So I have reviewed the case, and that's not correct slide. So in some parts it was really necrotic, but still it's seminoma, necrotic. But in some blocks there were very small foci in 2 or 3 blocks of this component, and this is not seminoma, this is embryonal carcinoma. So this is why the patient has got recurrence, because mixed germ cell tumors are treated by different chemotherapy protocols when compared to classical seminoma. And again, metastatic disease in 6 months is not what is expected for classical seminoma.
I think that is the Yorkshire tumor. Now you see the
maybe
deposits, it's parietal differentiation.
Maybe here. I was not sure about that. So it doesn't matter. It's mixed germ cell tumor. And
your side is still treated differently. Okay. There might be really tumor.
I was not sure whether it's inflammatory, but.
So these eosinophilic deposits around the cells are considered to be incipient differentiation. These collagen-like deposits. You will see it later.
So this is a very nice case. This is a biopsy coming from 11-year-old boy with a diagnosis of recurrent tumor in outer auditory canal. So it's a skin biopsy. And clinical diagnosis was recurrent polyp of external auditory canal. And what you can see is this funny looking proliferation of adnexa, but what the real lesion is this myxoid thing here. So it's hypercellular lesion composed of this myxoid stroma with blunt spindle or stellate cells, and it's a cutaneous myxoma or angiomyxoma, and this lesion is causing this so-called induction of cutaneous adnexa. Sometimes this proliferation may be tumor-like, and I've got one paper about that.
Carni complex, is that?
It's 11-year-old boy, so I suggested they should perform genetic testing for Carni complex, because in this very young age, cutaneous myxomas are part of the syndrome. And this is paper by our group, published by Denisa Kacarowska, about patients with skin myxomas, and these myxomas causing this proliferation of skin adnexa, which in some cases are almost like tumor-like or are reminiscent of some skin adnexal tumors. So you should not confuse the lesion with skin adnexal tumor, because the main lesion is cutaneous myxoma, and you should recommend genetic testing for Carni complex.
We can do it as well.
Yeah, but it's a consult case from Slovakia.
They should send blood and we will do it.
Okay. So again, this is very basic pathology. This is cholecystectomy for some cholecystitis and cholecystitis chronica, and you can see already here some changes: pseudopyloric or pyloric metaplasia. In some parts, some intestinal metaplasia. And whether, if you are asking whether this epithelium is dysplastic or not, so I cannot really rule out low-grade dysplasia, but it does not matter, okay? Low-grade dysplasia or reactive versus this low-grade dysplasia, it does not matter. In the gallbladder, high-grade dysplasia is what matters. In that case, you always have to submit the whole gallbladder, and high-grade dysplasia is always straightforward diagnosis. So these are other parts, and you see this really high-grade dysplastic epithelium. So when thinking about dysplasia high-grade, it's really straightforward and it's widespread in the gallbladder. It's almost never very focal lesion. It's widespread. Okay, so I had this morphology in many blocks. And in addition, you have to submit the whole gallbladder and search for carcinoma. So sometimes this plastic epithelium goes down into the Rokitansky-Ashov sinuses, and you cannot tell whether it's invasive or not. But in this particular case, these glands are so haphazard, and we have these atypical looking very small glands which are not Rokitansky-Ashov sinuses. So I believe it's invasive carcinoma already. So the main thing I wanted to show you is that high-grade dysplasia is what matters in the gallbladder, and it's always easy diagnosis. It's 1 second. Okay, if you start thinking reactive or dysplastic, it's probably not dysplasia. My last case is for people who do brain tumors. This is a consult case from Slovakia. It's posterior fossa cerebellar tumor. You can see cerebellar parenchyma here. It's a biopsy from 20-year-old male, so young adult patient. The tumor looks like this. It's very cellular, but still in my eyes a little bit piloid looking. It's composed from these cells. Some of them have really long processes, and some cases of pilocytic astrocytomas may have these ugly looking nuclei, and it's similar to schwannomas, where you may have these ancient atypical nuclei. So this is the case, but in addition, in my eyes, some of these nuclei are really ugly looking. So it's way beyond I expect in, let's say, regular, normal, common pilocytic astrocytomas, but this does not define so-called anaplastic pilocytic astrocytomas. We have to search for mitotic figures, which is very difficult if you have such a bizarre nuclei like here. So we have performed. Oh, I will show you one another stain. This is neurofilament staining. Most pilocytic astrocytomas have solid or expansal growth pattern. It means that if you perform synaptophysin or neurofilament staining, this is neurofilament staining, you will not have synaptophysin or neurofilament positive tissue. In this case, at least in some proportion of this lesion, you have neurofilaments. So in addition to showing expansal growth pattern, this tumor is infiltrative as well. But it's rare, but it may happen in pilocytic astrocytomas. And this is Ki-67 staining. Most pilocytic cytomas will have proliferation index close to 0 or 1%, 2%. So this is much higher, and here you can see there are lots of mitotic figures there. So we have performed genetics to rule out other thing, and the tumor shows very typical Kia-BRAF fusion with typical localization. I believe it's pilocytic astrocytoma, but because the proliferation is quite high and shows brisk mitotic activity, it was classified as pilocytic astrocytoma with anaplastic features. These tumors behave much more aggressively than compared to prototypical pilocytic astrocytomas. Most pilocytic astrocytomas retain their grade 1 for many, many years. They do not grow or grow very slowly or grow until some age of patient. The tumor affects mostly pediatric population and then stops growing, but very rare examples may recur or progress and develop anaplastic features and may even kill the patient. So probably this is one candidate which will behave much more aggressively. And that's it from my side.
Hello everyone, it's Michael here. I have two cases from last week. The first is a very unfortunate case of a young lady, 44-year-old lady. It's a routine biopsy sent to us by a private surgeon, so basically anybody can see a case like this. It was called tumor in the soft tissue in the head and neck area, unknown etiology, but a sarcoma was suspected. So we got few fragments that looked like this. So without even going on higher power, you can tell this is something very aggressive. It's largely necrotic. In some parts, it's myxoid like this, but there are also solid areas or more solid areas composed of these epithelioid to rhabdoid cells. There's high mitotic activity, atypical mitosis, and it's partially necrotic and also probably ulcerated, so there's a lot of inflammatory cells. I'll show one more slide. This is a different block from a different part of the tumor, but still very similar appearance. Look at the bizarre mitosis here, so super high grade tumor. So you start with doing some immunohistochemistry. This can be carcinoma metastasis, it can be of course sarcoma, it can be some undifferentiated melanoma. So we did a panel of immunostains, but the only positive marker were broad spectrum cytokeratins. So this is AE13, which shows this patchy expression, especially in these large epithelioid to rhabdoid cells. The clinician called later to tell me that the patient has a suspected metastatic disease to adrenals, and there is a suspicious focus also in her lungs. So again, broad immunopanel was done with TTF1 and all the relatively site-specific markers. Everything was negative. Eventually, because of the epithelioid and rhabdoid morphology, one marker was added. Anybody has a guess what could help here? Marianne and my father already know the diagnosis, so anybody has a guess? Yes, well, it's not SMARC B1, but it's SMARC A4. This is a SMARC A4 immunohistochemistry. You can see the inflammatory cells have a diffuse strong positivity. The large epithelioid cells in between are negative. So this is most likely a SMARC A4 deficient sarcomatoid undifferentiated tumor, and most likely the origin is somewhere in the lungs or thoracic cavity. The clinical course and the age of the patient is unfortunately perfect for this disease. So a relatively young patient, widespread metastatic aggressive disease, and also the morphology is very good. These rhabdoid epithelioid cells with abundant cytoplasm and high-grade features. So for those that did not watch our seminar last week, we showed two live cases last week, and this is another case in 1 week. So and actually it's a fifth case for me in less than a year. So these tumors are not at all that rare. Unfortunately, it's a basically untreatable disease, extremely aggressive, and the patient will not do well. Okay, another case. This was a 14-year-old boy with a aggressive-looking tumor on his foot. And again, without going on higher power here, you can tell this is not going to be anything good. Very dark blue basaloid neoplasm with necrosis. You go on higher power, you can see this is a mostly small round cell neoplasm. So first thing in this age group you should think of is probably Ewing sarcoma. There was CD99 and NKX2.2 done. Both were completely negative. Next thing you should consider in this age group is rhabdomyosarcoma, especially with this morphology alveolar rhabdomyosarcoma. But this is desmin, completely negative, except for the infiltrated skeletal muscle fibers. Otherwise, it's desmin is negative. Next thing I would do with this morphology, I would do, I did DUX4 immunostain, which, as we have also shown in our recent paper, is an extremely good marker for chick DUX4 sarcomas. Here is some positivity, but this is cytoplasmic, and the specific positivity is nuclear. So nuclei here are completely negative, only non-specific cytoplasmic staining. So this is most likely not chick DUX4 sarcoma. Of course, we did S100, SOX10, all other markers, and basically after everything was negative, we decided to do next generation sequencing. However, I did a mistake here because of this morphology. As I mentioned, besides Ewing sarcoma, alveolar rhabdomyosarcoma is high on the list, but after seeing negative desmin, I just thought it's not going to be rhabdomyosarcoma. But the fusion was PAX3, FOXO1, which is typical for alveolar rhabdomyosarcoma. So I added MyoD1, myogenin, and you can see that there is probably not a single cell which would be negative here. So again, the lesson for everyone, including me, if you are after rhabdomyosarcoma a lot, don't end with desmin. Always do other markers, especially MyoD1. Sometimes I still forget about this. So alveolar rhabdomyosarcoma, PAX3, FOXO1 fusion. Next case, this was a 60-year-old lady with a lesion on her elbow. So we see here the skin surface and the adjacent dermis infiltrated by these clear or cells with clear cytoplasm. On very low power, I thought about granular cell tumor, but on higher power, you can appreciate this foamy or bubbly cytoplasm. This looks more like histiocytes. Well, still, we did S100 and SOX10, which are negative. And instead, the histiocytic markers are diffusely positive like this. So basically all the cells in question are diffusely positive for histiocytic markers. So you can start thinking about some histiocytosis and this kind of stuff, but these cells are completely bland. They look more like foamy macrophages, and it's in an elderly lady, and it's close to a big joint, close to elbow. So this is, or I think this is a tuberous xanthoma, completely benign lesion, typically found in patients with dyslipidemia. Another case is an elderly patient tumor on the foot. So we have this relatively small sample composed of this myxoid tumor. But there are also solid areas with more hyalinized parts, in which you can see these large cells with these prominent eosinophilic nuclei, also here. So these RS-like cells almost. There's mixed inflammatory infiltrate admixed with the neoplastic cells. Some mitosis, some atypia here as well. So with this morphology, you can, of course, think about myxofibrosarcoma. It could be that was one of my considerations. But with this cytology of the neoplastic cells, I was more inclined to call this myxo-inflammatory fibroblastic sarcoma.
Great, huh?
No, conventional grade.
Yes.
There are also some, in the more solid area, some cells with emperipolysis, which is common finding, which is non-specific, but it's part of the overall picture.
Again, what patient was that?
It was on the foot of elderly patient. So this is a low-grade sarcoma. It should be definitely re-excised, ideally with white margin, otherwise it will very likely recur. But the chance of metastasis with low mitotic activity like this is very, very low, 1 or 2% perhaps. There is no immunohistochemistry which can help you really. Immunohistochemistry has no role in the diagnosis. Okay, next case, there was a 42-year-old male, tumor on his forearm, which was deemed to be malignant, both clinically and by MRI imaging. And on low power, it also, to me, looked quite possibly a sarcoma, infiltrative growth. It was infiltrating into skeletal muscle. There were also kind of like satellite nodules of this tumor in other sections. The tumor is, of course, very cellular. But then again, if you go on higher power, I started to consider some other diagnoses, because although it's cellular and there are some mitoses, there is almost no atypia. No atypical mitosis. And there were areas like this, where you have extravasation of erythrocytes, and small so-called pseudocystic spaces like here. And in this part, it looks more conventional. Any idea? Yes. This is nodular fasciitis, cell variant of nodular fasciitis, which often look very scary histologically and very often are misdiagnosed for sarcoma. Because the clinicians were quite suspicious for malignancy, I also did FISH for USP6, which was positive. So good, happy news for the patient. Another section from the same case. You can see these kind of like, I don't know if to call it satellite nodules, but it's definitely highly infiltrative. And in many parts it looks quite ugly, but then you have these conventional looking areas with erythrocytes and pseudocystic spaces. Sometimes you can see giant cells here. So quite typical example of nodular cellular variant of nodular fasciitis. Another case, this is a 1-year-old boy with a tumor on his back. So skin excision epithelium is normal, and in the dermis you see these large eosinophilic cells. My first thought was it could be rhabdomyoma, but then when you go on higher power, there are no cross striations, and these cells look histiocytic, or one possible lineage could be histiocytic, and indeed there were CD163 and CD68 diffusely positive. There was not many giant cells, not too many inflammation, and these histiocytes had this very prominent ground glass cytoplasm. So it's one of the histiocytic disorders. You can think about Rosai-Dorfman or juvenile xanogranuloma or solitary, or we don't know if solitary or not, but most commonly we see solitary reticulohistiocytoma. You can see some cells with emperipoiesis, but it's not very widespread. So this is, I think, this is also given the age, 1-year-old boy, solitary reticulohistiocytoma. Or again, reticulohistiocytoma, most likely solitary, but excludes systemic disease because occasionally this can be a systemic disease. So emperipoiesis can be found in these cases, but usually very focally, and the inflammatory reaction around it is not very prominent. In this tumor, the inflammatory reaction in this tumor is not very prominent. And at the end, two very easy, common general surgical pathology cases, which are, however, problematic for general surgical pathologists because they don't see this so often. So this is a lady, 80-year-old, with a tumor on around her scapula, I think 10 centimeters in diameter, approximately. And you see this is a well-differentiated fatty adipocytic neoplasm, which on first sight looks like a lipoma, but on a second sight you see this variability in the size of adipocytes, which is normally not found in conventional benign lipoma. And occasionally you see this spindle cell stroma. So many people start thinking about atypical lipomatous neoplasm. But again, we are on the back of an old person. In this case, it's a lady. It's a male, but it can be a lady as well. And we have, when you look at the stroma here, it's not this fine collagenous fibrillary stroma as you see in atypical lipomatous tumor. I'll find some better slide, but it's composed of these ropey or very broad collagen fibers, such as those seen here. I'll show some better area as well, and some very bland, non-hyperchromatic spindle cells. So this is spindle cell lipoma. In this case, there is a lot of fat tissue without the stromal component, but in some areas you can find these very, very broad collagen fibers. ropey collagen fibers, for example here. If you do CD34, this will be diffusely positive, these stromal areas, and if you do retinoblastoma protein, the spindle cells will have loss of expression. So, and last case was a 50-year-old lady with a tumor on her face. Small, circumscribed tumor, quite cellular. When you look at the cells, the tumor cells, they look actually quite similar to the tumor before. So bland, short spindle cells. And when you look at the collagen, it's also identical. It's ropey collagen fibers. But where is the fat? Unfortunately, there is a so-called fat-free variant of spindle cell lipoma, which can exist and rarely occurs. In this case, we have some fat at the edge here, so this might be part of the tumor. Maybe it's just surrounding tumor. I don't know, but on the face there is usually not so much fat tissue, so this might be part of the tumor. Who knows? But in this case, of course, it's good to add some immunohistochemistry. So CD34, diffusely positive. We also did some other markers, S100 protein, and these common markers, everything was negative. And this is retinoblastoma protein, which is positive in some of the inflammatory cells, and there is loss of expression in the tumor cells, which confirms the diagnosis of fat-free or fat-poor spindle cell lipoma. Okay, this is all. I don't have any other cases this week, so let's see somebody else. Let's hear somebody else.
So, good afternoon to everybody. I have just one entity, probably either the same entity or very similar entity occurring across various organs. The first example is from pancreas. So this is a tumor of the pancreas. You can see the normal pancreatic tissue at the periphery, and here the paler parts of the area is the tumor, and it is not so rare tumor of the pancreas. It is called solid pseudopapillary neoplasm or solid pseudopapillary tumor, which is a typical tumor of female patients, and it is very frequently large. With areas of hemorrhage or pseudopapillary areas, but it can be also small and look like this. So it means there is lesser chance of degenerative changes occurring in the tumor. And this is the case of smaller tumor, so it is more compact, without degenerative changes, and with quite a lot of amount of these signaturing cells. So this is a typical example of solid pseudopapillary neoplasm of the pancreas, and quite or very similar tumors or identical as for morphology can occur in the testes and also in the ovary, and we are planning to do a study comparing regarding epigenetic features of these tumors, specifically methylation analysis comparing this entity or probably the same entity occurring in pancreas, ovary, and the testes. So this was the tumor of the pancreas. Then here we have example from ovary. So this is ovarian tissue, and I have to find the tumor. Here, sorry. So here is ovarian tissue, and in ovary, you can see that there is as for morphology, the tumor is the same as we saw a while ago in pancreas. And in ovary, there is established diagnosis of solid pseudopapillary neoplasm, and in ovary, these tumors are regarded as analogic tumors as in the pancreas, which is further proved by the identical immunohistochemistry and genetic analysis. These tumors are positive nuclearly for beta-catenin, followed by mutation in exon 3 of the CTNNB1 gene, both in tumors, both in pancreas and in ovary. Another antibodies positive in both entities or in both locations are CD10, cyclin D1, CD56, NSE. Sometimes cytokeratins can be positive. So in ovary, this is the same tumor and it is well-established entity. But we already published and I'm planning to publish on this topic more, that the same tumors are occurring in the testes, but in the testes there is no existing diagnosis of solid pseudopapillary tumor, and these tumors are called rather sertoli cell tumors, NOS, so not otherwise specified. This tumor is not the most beautiful one with signature morphology, but I hope I'll have later the better examples. But as for cytology, these tumors are the same as we saw in pancreas and ovary, and if we do immunohistochemistry, the immunoprofile will be largely overlapping with pancreatic and ovarian tumors, and as well as genetic features. So there is beta-catenin mutation or CTNNB1 mutation in the testis as well. The only slight difference is that in the testes and in ovaries, these tumors are more frequently positive for SF1, and in pancreas there is usually these are usually negative. But this is so far the only difference regarding immunophenotype which we found out. So that's also one of the reasons we plan to search more if there is a genuine analogy between these tumors or not. So this was an example from the testes. There is one more case from the testes. And this is more similar than the previous one was to the examples I showed you in pancreas and in ovary. That here is also signaturing cell morphology. In ovary, there is also an entity called signaturing tumor of ovary, and it is also established as single entity. But we think that these signaturing cell tumors and solid pseudopapillary neoplasms are in fact the same tumors, supported by the fact that signaturing cell morphology can be also typical for solid pseudopapillary neoplasms of the pancreas if they are small, and the reason why the signaturing cell morphology or this morphology is more typical in gonads and rather rarely seen in pancreas is that in gonads the tumors are usually smaller because we found out earlier that there is some tumor mass, especially if it is in the testis, than in the pancreas, where the tumors can grow without knowing that the patient has the tumor. So this was example from the testis, signaturing cell semicolon or solid pseudopapillary neoplasm, and now we also want to add to our study the case from the testis which are proven sertoli cell tumors NOS, and this is a tumor of the testis called sertoli cell tumor NOS, and it was signed out by an GU international expert from pathology. And you can see that this tumor is the same as for morphology, and also the immunophenotype is the same. So we think that these sertoli cell tumors NOS and signature cell stromal tumors or solid pseudopapillary neoplasms of the testis are the same entity, which we want to further prove by methylation analysis. And we also think that these tumors are not actually sertoli cell tumors, but rather are more akin to pancreatic tumors, and that this type of tumor can occur across both gonads, and they are similar to pancreas. But we are still in a step of collecting cases, especially where we have only a few examples of these tumors. So we are waiting to collect more cases to start the analysis. And this is the last example of the same thing. This is a tumor of the testis, which is rather similar to solid pseudopapillary neoplasms of the pancreas than to the signature cell stromal tumor, but this is rather because this tumor is larger, so it also has degenerative changes like pseudopapillae, which are the result of degeneration after hemorrhage. There are also leftovers or consequences of the hemorrhage. Here you can see hemosiderin. There are only scarcely signaturing cells seen, but here at the periphery of the tumor, it was here, the morphology is again the same or very similar to the small tumors, and also we can see some signaturing cells in here. So we again think that this tumor, despite it looks like a little bit different from the small signaturing cell tumor, is the part of the same spectrum. And also in these tumors are also quite frequently seen these hyaline globules, which you can appreciate in the middle of the screen, and these structures are also quite characteristic for solid pseudopapillary neoplasm of the pancreas. So we will see what the results will be, but we think that there are quite a lot of reasons to think that these tumors have a lot in common. So this was my last case, and now.
I will continue on this topic. My name is Michael. I am continuing on this topic because it's very hot thing in our laboratory. And first I would open the last one. Yeah, it is this paper that we published 6 years ago, and it describes what was said here by my colleague. Yeah, you can download the reprints after this session. Yeah, that means we think that these signet cell stromal tumors of the testis are actually signet cell changed solid pancreatic pseudopapillary neoplasm. Ten první reprint. What is very important is that all these tumors are immunohistochemically positive for this very novel antibody ABCD1. Yeah, it was introduced to pathology just in the May issue of American Journal of Surgical Pathology, so that we tried this ABCD1 antibody on all of these tumors, and all without exception are positive. Yeah. And now I will show you a case that was published by Markku Mietinen and Jerzy Lasota. And they published one case of signature cell stromal tumor of ovary, very similar to the one my colleague Květa showed here. You see ovarian tissue here, yeah? Co? Yeah. You see very nicely signaturing cell morphology. In the paper they say they did beta-catenin mutation which was mutated in exon 3. And now this is immunostaining with antibody ABCD1. And you see it is granular positivity inside of cytoplasm because this antibody stains peroxisomes which have cytoplasmic structure. And the same, we found positivity for SF1. You see nuclear staining SF1 positivity, which clearly shows that this positivity is not specific for any sertoli cell tumor, so that we think that this case is another example of signaturing cell change of solid pseudopapillary cystic tumor of pancreas. With all these tumors in testes and in ovary, so far described, behaved in a benign way. And now I have here a very interesting case of lesion of appendix. And you might see that at the tip of appendix there is such fibrous lesion with inflammatory admixture. And what is not well seen is that some of the cells are epithelioid, single cell, or in row of cells which are cytokeratin positive. You can find it in your routine material as well. Just take fibrous appendicitis. Yeah, it is usually final stage of inflammation of appendix, and you see these single cells positivity here in between the inflammatory tissue. The same cells are very nicely immunohistochemically positive for synaptophysin and chromogranin. With synaptophysin, you see this. Many of these cells are synaptophysin positive. And what was amazing, it was in just the original slide, but I'm not sure I have it here. I hope so. There was incipient small carcinoid arising in the tip. No, I don't have here this. Yeah, here. Look, very incipient carcinoid arising in these cells. And it's amazing that this was already described by Pierre Masson in 1948, 1949. And he just by H&E staining and silver staining recognized that epithelial tumor-like carcinoid can arise from fibrous tissue. It is usually incipient, classical, very benign carcinoid in the tip of appendix. I'm sure if you repeat my staining in all fibrous appendicitis, you will find the same finding as I did. That means that you will see that regular changes in fibrous tissue, which is usually S100 protein positive. I will show you the S100 protein positivity in these tips of appendices. Yeah, it is. Yeah, you see what looks like fibrous tissue. It's not fibrous, it is neurofibromatous proliferation. Yeah? And in these neurofibromatous proliferation arising these epithelial cells causing sometimes creation of carcinoid of the appendix, nowadays called neuroendocrine tumor of appendix. Next I have here simple thing, it is cystic lesion of vulva. And you see it is just big cystic lesion. Someone would like to say it's cyst, simple cyst, but I think so that it's not only cyst because you see epithelial proliferation at the wall of the cysts. And if you magnify these lesions, you find that the morphology is very similar to lesions of breast. Yeah, and when you find whatever that looks like breast pathology, it's always arising in so-called anogenital glands of vulva, and anogenital glands of vulva have perfect similarity to breast tissue, and they give rise to all tumors like in the breast. Just the frequency of these lesions are very different from breast. I will show you in the future some various proliferations arising in anogenital glands of the vulva, because we published about these amazing lesions here for 20 years in the past. I think it's the time.
So what is the lesion called?
I would call it adenoma rising in anogenital glands. They were described in 1991, so that relatively very recently. They were not suspecting that they even exist. Yeah, I will come back in the future to these glands and the whole pathology, because it's entirely new pathology, and without knowing these lesions, no dermatopathologist can diagnose reliably lesions of vulva. Yeah, I would like to thank for attention. Yeah, and I would like to say that next week we call off the seminar because most of the speakers will present in Mexico, in Cancun, in World IAP, so that if there is watching us, anybody going to Cancun, to Mexico, we will see you next week in a presentation of Riveling Club, where we make quite big part of the program of Riveling Club that is incorporated into World IAP Congress. Thank you for attention.